So I'm very much hoping that you will enjoy this presentation. And why is my slide not advancing? That's better. And I want to turn you from this gentleman. You can imagine an ECG screwed up in this furious hand and take you to the promised land of happiness and synergy with ECGs. So, and if nothing else, I want to ensure that if you do get a tattoo, you do not end up with this electrically inaccurate ECG, which maybe looks pretty but is totally wrong. So as I say, if you're interested in bradyarrhythmias, there is a talk available on the YouTube channel, so please look there for bradyarrhythmias. So I'm going to concentrate on narrow complex tachycardias and broad complex tachycardias today, and we'll start off with the narrow complex ones and work our way forwards. So please use the chat to give me some answers for what you think of the ECGs, and we'll get straight on in with this one. So the most astute of you will probably tell me immediately this is not a tachyarrhythmia, and you will be completely correct. But what does this ECG show? Yeah, so this shows atrial fibrillation. And if you look, you can see an irregular baseline. If you look really carefully in some places, can you see you've got what look like P waves? And the key to this is to say, if those are P waves, then the next time there's a flat segment, we should still see them. So if you could see those bumps occurring throughout the trace, I might buy this as an atrial tachycardia or possibly an atypical atrial flutter. But you can see immediately as you move on to the next T to P segment where the baseline is flat, that it is just noise and irregularity, and these just happen to look a little bit like P waves. So this is atrial fibrillation. You've got a profoundly irregular RR interval, no question about regularity on that ECG. And if you're not sure, the way to check it out is to mark your R waves on a separate piece of paper and then slide the piece of paper along to see if the marks you've made line up with the QRS complexes further along the ECG. And you can see immediately when I do that here that there is absolutely no correlation at all. So this is an irregular rhythm. So narrow QRS, normal-ish axis. The only thing really going on here is the atrial fibrillation. What about this ECG? Apologies that it's not as good a quality ECG. I must update it to a better one, but this addresses the point that I'm wanting you to pick out. So what do you think the heart rhythm is here in this tachycardic ECG? So the big question here that I'm really asking is, do you think this is an irregular rhythm, or do you think this is a regular tachycardia? Because if you think it's irregular, then we're happy saying that this looks like atrial fibrillation. Welcome if you've just joined us. You've not missed a great deal so far, just a little bit of preamble. And this is going to be a talk on tachyarrhythmias. So starting with narrow complex tachyarrhythmias and moving on to broad complex. So thank you. You can't see a P wave, bit irregular, not sure. Another person saying it's fairly regular. Yeah, I think it does look fairly regular, doesn't it? So this is an example where it's very hard to eyeball this and say, is it regular or irregular? Whereas if you draw your lines on, as I showed you a moment ago, and ratchet those across and try and line them up with an R wave, you can immediately see that this is actually really quite irregular. And as a rule of thumb, you're looking for about a 25% difference between the longest and the shortest RR interval in order to say that it's irregular. I mean, any rhythm can be very slightly irregular, but more than 25% difference between the longest and the shortest RR interval, then you can call it an irregular rhythm, and you're very much thinking atrial fibrillation. So here, can you see how marking it turned it from a I'm not sure into a, oh, it's a very clearly atrial fibrillation. So this is fast atrial fibrillation. What about this ECG? I was very disappointed when I was preparing this presentation because I saw somebody with a beautiful ECG like this just last week, and unfortunately I didn't take a photo of it. So I've had to poach one off the internet. So what does this ECG show? So it's a supraventricular tachycardia. Yeah, I agree with that. But can anybody be more precise? So I prefer the term narrow complex tachycardia because a supraventricular tachycardia can be broad complex if you have left or right bundle branch block, and a sinus tachycardia, for example, just exercising. So narrow complex tachycardia, to point out that these are narrow QRS complexes, is my preferred term for this sort of thing if you're giving a sort of an umbrella term. But what of the various possible causes of supraventricular tachycardia do we think this is? So have a look at lead 2 at the rhythm strip. And can you tell me anything about the appearance of the rhythm strip? Can you tell me about, is this regular or irregular? So I've had regular with atrial ectopics. What's the rate of this ECG before we get as far as the rhythm? Does everybody know how you work out the heart rate on an ECG? So we can either do 300 divided by the number of large squares between QRS complexes, or you can count the number of QRS complexes on the 12-lead ECG and multiply by 6. So here it's much faster to say that there are about 2 large squares between QRS complexes. So the rate here is about 150. In fact, it's slightly faster than that, maybe 155, because you can see it's slightly less than 2 large squares. So does that help you coming to a diagnosis? We've got a narrow complex tachycardia, rate of 150. What's the classic narrow complex tachycardia that gives you a rate of 150? Yeah, atrial flutter with 2-to-1 block. So can anybody see a flutter wave? What are we looking for when we say flutter wave? So we're looking for a sawtooth pattern in the baseline. And can you think about if you turn this into a saw? Do you think you could chop down a tree with it? I mean, I think this looks pretty much as good as one of my saws. I've got quite a few of them. So this sawtooth pattern is what points you towards it being atrial flutter. Now in atrial flutter, you have a circuit going round and round in the atrium. So in the right atrium, you've got, it just goes round and round in the right atrium, and it goes round at a rate of about 300. And every time it gets to the AV node, it tells the AV node to trigger the ventricle. But your AV node, generally speaking, doesn't like going at a rate of 300, but it very happily goes at a rate of 150. So atrial flutter can actually be really quite hard to rate control because you have this very organized circuit. So you have a big shout at the AV node 300 times a minute. It ignores half of those, so you get your rate of 150. But trying to get it to ignore any more of those, you're going to end up having to deafen it to the point the patient goes into complete heart block in order to slow them down, particularly a young person with a healthy AV node. So it can be really hard to rate control. Because it's a very organized circuit, actually all you need to do is burn anywhere along the line of that circuit, and they choose the narrowest point of the circuit, which is actually at the little narrow strip between the tricuspid valve and the vena cava. If you burn across there, then you block the circuit, it can't form, you cure the atrial flutter. About 95% cure rate, simple procedure, low risk. So we can ablate this very effectively, but when it's hard to control with medications. Atrial fibrillation, very similar in so many ways, needs anticoagulating, almost sounds the same, but is incurable. It can only ever temporarily be improved and is a really challenging thing to try and keep you in sinus rhythm. In some patients. So atrial flutter, atrial fibrillation, very different. Often you see both together in a patient, but very different rhythms. So here you have the sawtooth on the baseline, and you have a rate of about 150 because the circuit is going at 300 and every other beat is conducted. You can have variable rates, but it has to be divisible by that atrial circuit rate. So if your atrial circuit is going at a rate of 300 and every third beat goes through, it gives you a rate of 100. Or if every fourth beat goes through, it gives you a rate of 75. So you can have RR intervals that are compatible with a heart rate of 75, 100, 150, but you can't have an RR interval that's compatible with a rate of 120. It's impossible that that would be conducted with atrial flutter. So either that's some sort of ectopic beat or it's not atrial flutter. It's very easy to diagnose atrial flutter if you just slow the rate down a little bit. So this, can you see, you wouldn't have any doubt immediately telling me here's your sawtooth pattern. And here we have again atrial flutter, but this time we've got a higher degree of block. So we've got here 300 divided by 4. So we're down to about a rate of 75. And so there'll be a flutter wave buried in the QRS here. You can see 1, 2, 3, another one buried in the QRS here, 1, 2, 3. So here this is 4-to-1 block with atrial flutter. So in order to make the diagnosis, we could try getting the patient to a Valsalva maneuver. If they didn't look like they were going to have a stroke, if you rubbed on their carotid artery and they didn't have a carotid artery buoy, you could think about rubbing on their neck. I'd be always a bit cautious of doing that because there is a real risk of a stroke. I'd much rather do a Valsalva maneuver. You could also give some adenosine, which would help you to the diagnosis if you're unsure, but usually it's reasonably obvious. So look at the sawtooth baseline here and then look at it here. You can also see the 2-to-1 flutter wave in V1, for example, over here, but in this patient it's most clear in lead 2. Everybody happy with that? So moving on, what do you make of this narrow complex tachycardia? So You'll obviously check for me the patient's name, their date of birth, you'll confirm it's their ECG, and then you'll move on and tell me that the QRS duration is less than 120 milliseconds, so it's a narrow complex tachycardia. And you'll tell me it's tachycardic. Can anybody tell me the rate? Yeah, it's about 150 again. So here, can you see it's fractionally longer? So actually, it's probably about 145, so slightly less than 150. So we should immediately be saying, is there a flutter wave? And I think if you look here just before the QRS, it looks pretty flat. So we can't see any evidence of a flutter wave. You also can't see any evidence of a P wave. So sinus tachycardia is a common cause of a narrow complex tachycardia, and usually it becomes very obvious if you monitor the patient because the rate increases and slows down, and P waves can become visible or merge with the T wave if you have first degree heart block. So it's conceivable that there is first degree heart block and our P wave is buried in the T wave, but the absence of any sign of a P wave makes this unlikely to be a sinus tachycardia. So can anybody tell us anything else about this ECG? Anything else to spot in this ECG that might help us to a diagnosis? Have a look in lead 2. Can you see anything about this that doesn't look like a normal part of the ECG? Delta wave, yeah, I can see what you're trying to tell me, but if you look, there's pretty abrupt. Yes, very good, Malvika. So can you see here? Every QRS is followed by a little deflection, downwards deflection before the T wave. So what's going on there? Is that a very strange biphasic T wave, which can be seen everywhere? Is that a part of the QRS? But it's a lovely narrow QRS. This is a very sort of slow deflection occurring significantly after the QRS seems to have completed. So what do you think that little deflection is there? Thank you. So this is a retrograde P wave. And so what does that make likely to be the diagnosis when you see a retrograde P wave occurring just after the QRS? Yeah, it makes it likely to be an AVNRT, an atrioventricular nodal reentry tachycardia. So everybody knows and understands what an AVNRT is, don't they? So let me try and explain it to you. If you remember the electrical conduction system of the heart, and we've got the right atrium over here, the left atrium over here, and we've got the ventricles underneath. And you normally have the natural pacemaker in the sinus node going to the AV node and then down through the bundles of His with the left and the right bundles down to the ventricle. Now, an AVNRT is all happening inside our AV node. And if we magnify that, what you have to think of is that there are two pathways through your AV node. There is a fast pathway, and I want you to think of that as a hare, and there is a slow pathway, which is, of course, a tortoise. And everybody knows the story of the tortoise and the hare, don't they? So the tortoise and the hare have a race, and the hare sets off confident very fast and then has a nap. And the tortoise slowly trundles along and eventually wins the race because it doesn't stop for a rest. And if you have an AVNRT, it's because your AV node has got a hare fast pathway and a tortoise slow pathway. And about a quarter of people have got this physiology. Far fewer of them end up with AVNRTs, but it's important, therefore, we can actually induce the arrhythmia during an ablation in order to know that that is the cause. So we like to stop medications so that we can actually induce the rhythm we're trying to fix during the procedure. So if we just look at how that works in a little bit more detail, imagine the normal situation where your atrium fires, the signal goes to the AV node, and then the hair fast pathway rushes around and triggers the ventricle. Meanwhile, the tortoise slowly trundles round and it doesn't get to do anything because this bit's depolarized and can't be stimulated by the time it gets there. So watch again. Atrium goes, hair whizzes round, triggers the ventricle. Tortoise finally gets there, by which time everything has already happened and it doesn't get to do anything. But the last thing that happens, if you look again, is the pathways repolarize. And can you see the tortoise one repolarizes faster because it doesn't need as much of a rest as the fast pathway. Now, what that means is if you end up with a premature atrial signal like that, the hair whizzes round and meets the depolarized tissue that it can't stimulate, so it gets blocked. Meanwhile, the tortoise finally gets to go round and stimulate the ventricle. If you look at that again, so the normal happens and the hair gets there first, but the premature one arrives and the hair gets blocked by its own pathway not being ready to go. It needs to sit down and have a rest. And our tortoise gets to go all the way around and stimulate the ventricle. Now, it doesn't stop there because by the time it gets to the ventricle, the fast pathway is ready to go again. And electrical wires in the heart, just like electrical wires in the computers and all the rest of it, they conduct both ways. So the tortoise finally gets to trundle all the way back round to the atrium and stimulate the atrium. And then it goes round to the ventricle and stimulates the ventricle. And then it goes back up to the atrium and it goes round and round and round. And so depending upon your AV node's health, you can get a heart rate that's really fast or relatively slow rate of about 150. If you've got a young person with this, their rate's probably more like 200. And very often, if you have a 12-lead ECG, what you see is normal beat, premature atrial contraction, and then our tachycardia starts up. And then it can be terminated spontaneously or take a long time to be terminated. Things like Valsalva maneuvers can help to get rid of this, or splashing cold water on the face or rubbing on the carotid or adenosine. All of these will break the conduction. And because the signal whizzes up from the ventricle up to the atrium, this is why your P wave can occur just after the QRS or even within the QRS. So you might not see it here. You can't see an obvious retrograde P wave, but often you can. And that points you towards it being an AVNRT. I hope that makes sense to everybody. You can easily summarize it with these diagrams showing the fast and the slow pathways, but I like to talk about it as the tortoise and the hare because I think it's easier to remember like that. Now, the other common condition which gets confused with, can anybody tell me what it is? What's the other common cause of a narrow complex tachycardia that gets confused with an AVNRT? So I'm sure you're all typing atrioventricular reentry tachycardia, or AVRT. So the lack of an N in the name makes all the difference here. And this condition, you have an accessory pathway. So this is Wolff-Parkinson-White or Lone-Ganong-Levine syndrome, or there are lots of other names for them, but this involves an accessory pathway. And so what happens here is that you normally get a signal from the sinus node, which goes through the atria and only through the AV node to the ventricle. But here, the accessory pathway is an electrical wire that shouldn't be there that connects the atrium to the ventricle. And it can be anywhere. It could be here over on the left free wall, which is often where it is, but it could be over on the right side or close to the AV node. It can be anywhere. And the appearance of it in the ECG can really help you locate it if you know what you're looking for. But from your point of view, just look to see if the PR interval is short or if there's evidence of a delta wave. Now, in an accessory pathway, the signal goes either down through the AV node and then back up through the accessory pathway, and that gives you a narrow complex tachycardia. Or more rarely, it can go down through the accessory pathway, back up through the AV node and go round and round in a antidromic, it's called, orientation, and give you a broad complex tachycardia. But you're looking for a delta wave on the resting ECG, which may or may not be present, and you're looking for evidence of a narrow complex tachycardia. And it's important because this patient is at risk of sudden death if they were to go into atrial fibrillation, because the accessory pathway may be able to conduct very fast indeed, and normally your AV node protects you from the rates of 300, 400, 500 in the atrium with AF. And if it goes through the accessory pathway and you pace the ventricle at rates much over 300, that will quite nicely put you into VF. So that's why it's dangerous. And patients with Wolff-Parkinson-White are at higher risk of atrial fibrillation. So that's the difference between AVNRT, where it's all in the AV node and you have these two pathways in the AV node, or an AVRT, where you have an extra electrical wire between the atrium and the ventricle somewhere it shouldn't be. Either of these we can fix with an ablation, and they're generally very amenable to being fixed, but there is always a danger you have multiple pathways or you have one that's in a location that's very hard to get at, but about a 95% cure rate. We can also use beta blockers to control symptoms, and particularly in AVNRT, that might be all that's required. But as soon as you've got an accessory pathway, a Wolff-Parkinson-White type condition, that needs to be considered for ablation because of the risk of sudden death if you went into AF. What does everybody make of this ECG? Yeah, very good. Thank you. So here you can see that the PR interval is very short, and it's what I've just been talking about. This slurred, slow onset of the QRS is our delta wave. So if you think of the QRS, it should go up really very fast, and we have got this delta wave between our P wave and the QRS. So slurred onset tells us there's an accessory pathway. So this is an ECG of a patient who's got Wolff-Parkinson-White syndrome. And if you want a diagram here's an example. You're looking for, sometimes it's a very obvious, sometimes it's a relatively subtle. But normally you should have a really abrupt onset, and the QRS tends to be wide. I mean, this QRS is about 120 milliseconds, and that's because of the delta wave. And this is another ECG. What does this show? Can anybody tell me about this ECG? So we have regular narrow complex tachycardia, very good. So the QRSs are starting to look a little bit on the wide side, but it is still, I would say, narrow, and it's a regular tachycardia. We can't see any retrograde P waves here, any evidence of them. Sometimes you see it as a little extra RSR type appearance in V1, but there's nothing there. So this, we can't say what's causing this narrow complex tachycardia at the moment. It could still conceivably be a sinus tachycardia. If the rate is very static at this speed, that would point towards it being an AVRT or an AVNRT, but we can't say which. But it's fast, isn't it? This is little under 2 two squares. So given this is, well, it's more than a little under, it's maybe 8 small squares. So the rate here is probably about 170. So this is a fast, narrow, complex tachycardia, and this could be either an AVRT or an AVNRT. So we treat this by doing basic Valsalva type maneuvers or splash ice cold water on the patient's face. In the past, we might have palpated their eyeballs to try and give them vagal stimulus to slow them down. Don't do that these days. Or carotid sinus massage. Again, be careful with that. Don't do that to a 90-year-old patient who's tachycardic like this, and that any of those maneuvers could break this rhythm. It's very useful to get a 12-lead ECG of the termination of this arrhythmia, and adenosine would be the sort of most optimal way of getting the patient out of it. You could also, beta blockers often work very well in terminating these things. Great, so that is all that I was going to say about narrow complex tachycardias. Let's move on to broad complex tachycardias. So my opening question, if you come across a patient with a broad complex tachycardia, it could either be a supraventricular tachycardia, and the patient happens to have left or right bundle branch block, or it could be a ventricular tachycardia. Now, if you don't know anything else about the patient and you've not seen the ECG, what proportion of patients do you think will turn out to have VT as opposed to a supraventricular tachycardia? So do you think it's likely to be a VT, or do you think it's likely to be something fairly benign that you don't need to worry too much about? Because if it's VT, you're going to get quite excited. So we've had a suggestion of 20%. Any advance on 20%? So 20% of the time our broad complex tachycardia will be VT. Any advance on that? Yes, so it's a very wise statement, Emmanuel. So investigate all as probable VT initially. You won't go wrong if you treat it as VT. You will go wrong if you treat a VT as an SVT. The answer is, I mean, it will depend enormously on the cohort of patients that you look at, but the answer that I'm looking for is about 80%. And it's to illustrate the point Emmanuel has just made. So really, if you see a broad complex tachycardia, you have to have a very good reason to not call that a VT. What about if you knew the patient had a history of some sort of cardiomyopathy? So you don't know exactly what, but they've got a cardiac history. So what would you say, did that increase the chances or does that decrease the chances? Do you think it's more likely this is a VT or less likely this is a VT if they've got a prior cardiac history? So the fact they've maybe had an infarct in the past, or they've got dilated cardiomyopathy, maybe they've got left bundle branch block as a baseline because of that. Do you think it means it's less likely they've had a VT or more likely? So I've had increase the chance put in the chat, and that's the answer I'm looking for. So if you've got an abnormal heart and a broad complex tachycardia, you need to be very sure that that's not VT in order to manage it as anything other than a VT. So if in doubt, treat as VT. In order to try and work out if it's a VT or a supraventricular tachycardia, you need to know, is it typical left or right bundle branch block? Now, if you're not sure, there's on YouTube, my Tachyarrhythmias presentation, I go through left and right bundle branch block in lots of detail. So if you're not sure, that's I'm told it's a useful presentation to look at. I hope you find it helpful. But look to see, is it typical left or right bundle branch block? Because if it is, then it could be conducted through the AV node. If it isn't, then it's going to be a VT, almost certainly. You can also do things like a Valsalva maneuver or carotid sinus massage or adenosine to distinguish VT, because if you can slow the rate down, often it becomes much clearer. But again, be very careful with something like carotid sinus massage. So what does everybody think of this broad complex tachycardia? So I've told you it's a broad complex tachycardia, which is always a good start. Thank you. It's left bundle branch block. So left bundle branch block, we're looking for either a V or a W in V1 and an R wave or an M in V6. So can you see this is left bundle branch block? And the next question is it typical or not? The fact that it's negative in V1 points strongly towards it being left bundle branch block, but there are lots of different forms of it. And because a VT has to be either left or right bundle branch block in morphology. But here, because we've got our V and our R, this is typical left bundle branch block. So typical left bundle branch block, it's tachycardic. What's the rate of this tachycardia? It's about 150. So can anybody tell me what the diagnosis is? Is this VT or is this something else? Yeah, very good. It's flutter. Can you see the sawtooth pattern? It's not as prominent as the one that I showed you earlier, but nonetheless, there is a clear sawtooth pattern throughout lead 2. So this is atrial flutter with 2-to-1 block, and the rate of 150 is the clue. So you might want to give this patient some adenosine in order to break the circuit, and then you'd see your flutter wave really nice and clearly, and that you could hang your hat on and know that this was atrial flutter. You might be able to achieve the same just by doing the Valsalva maneuver to slow down the rate briefly and reveal your flutter wave. But this is atrial flutter with 2-to-1 block and typical left bundle branch block. What about this ECG? Yes, right bundle branch block. Typical or atypical right bundle branch block? So in typical right bundle branch block, we're looking for an M shape in V1, but more than that, we're looking for a lopsided M shape, and it has to be little r, big R. So we talk about this being an RSR or M shape and little to start off with. If it's big, then little, that would be atypical. So this RSR pattern here, and we're looking for an S wave over here. So we've got our R wave followed by the S wave. So this is typical right bundle branch block. So that means that this could be a supraventricular tachycardia. Doesn't mean that it is, but the fact that it's so typical is suggestive that it might be. And we've got a regular rhythm. We can't see any retrograde P waves that help us out. Might possibly be something here, but that's probably still part of the QRS. So I would simply say this is probably a supraventricular tachycardia with right bundle branch block. I'd need to do further tests in order to be sure. What about this one? So do we think this is atypical left bundle branch block? So it's a bit difficult to tell which way up the QRS. Is it up or down? Can anybody tell me if the QRS is up or down? It's really hard to tell, isn't it? But it's atypical. And I think it's so this, as soon as you've seen the atypical nature of it, see how broad it is, see how slurred the onset of it is. Can you see that it doesn't follow the typical patterns we've talked about? This is now looking very much like a VT. So the rate here is about 170-ish. And we've got a broad complex tachycardia. Can anybody tell me anything else here that points towards this being a VT? Nobody? So everybody hold your right arm up in the air. That is the direction in which AVR is looking at the heart. So AVR over here is positive. Can you see that there is an upwards deflection here? That means that, hold your right arm up in the air again, the electrical signal is going up at your right arm. How is it, if it's starting in the atrium, that the electrical signal is predominantly moving upwards? It shouldn't be possible, and generally speaking, it isn't. So that tells you that there is extreme axis deviation, and that's because the signal's coming from the ventricle and it's going up from the ventricle towards the atrium and towards the right arm. So dominance in AVR makes it highly likely that it's a VT. Also, this is concordance, so all the complexes are pointing in the same direction. It's a bit difficult to tell which way, but that's only going to happen if either the signal's starting at the back and everything's coming upwards towards the chest. Remember, the chest leads are attached on the front of the chest, or if it's directed all negatively, the signal's starting on the front and it's all going backwards away from the chest leads. That's the only way you get concordance. So this grossly abnormal ECG with very broad slurred onset QRSs, which are concordant with extreme axis deviation, is undoubtedly VT. Does that make sense to everyone? Any questions with that one? So what about this ECG? Ooh, lots of pondering going on, I think, or hope. That's the reason for the silence. So, do you think this is a VT, or do you think this is a supraventricular tachycardia? And can you tell me anything that helps you one way or another? Do you think it's got broad QRS complexes? So if I'm having atypical left bundle branch block suggested, or was that, no, this is a new statement. Thank you, Emmanuel. So P waves within complexes. Yes. So let's just start from the beginning. And is this left or right bundle branch block? And the answer to that, I'm sure you're going to tell me, is that it's predominantly R wave in V1, therefore it's right bundle branch block. So my next question to you is it typical or atypical right bundle branch block? And can you see that there's just one R wave? There isn't an RSR pattern here, so that makes it atypical right bundle branch block. You can see that this is pointing upwards, this is pointing down, so we don't have concordance here. But what's the axis of this ECG? Can you see how in AVR, it's dominant in AVR, so it's pointing up towards your right arm. So it's extreme axis deviation, and that strongly points you towards a VT. So atypical right bundle branch block, extreme axis deviation. This is highly likely to be a VT, even though the QRS complexes don't look that unpleasant. They don't look that broad or abnormal. You might even say that are they even are they even broad enough to be bundle branch block? But they are. You measure the QRS in its longest lead, and they will be in V5. But this tells us it's probably originating quite close to the bundle of His. Now, these arrows are helpfully pointing at P waves, which every now and again you've got a quiet little bit of baseline you can see appearing just before the QRS. And you might say, oh, this is sinus rhythm, but there should be a P wave before every QRS for that to be the case. And you can see sometimes they're making the T waves bigger, and sometimes they're making this sort of almost a slurred delta-ish type onset to the QRS. And sometimes they're appearing as a big bulge at the end of the T wave. Now, you don't often see it as clearly as this. This is a great ECG, even though the quality of it's not that great. But you can see the P waves so beautifully here. And here, what we're looking for is AV dissociation. So is the ventricle listening to the atrium, or is it doing its own thing? And if you mark out these P waves, you can very quickly see that there is a totally different P wave rate to ventricular rate. So this is AV dissociation, and that is pathognomonic pretty much for VT. The other thing that we can look for VT that we haven't mentioned so far, there are two other things we can look for. Can anybody tell me? So we can look for capture beats and fusion beats. And capture beats are, you've got your VT trundling along, and there happens to be time for a P wave to appear and be conducted. Can you see the interval between this R wave and this R wave is just less than the rate of the VT, because VT's usually got quite a regular, well, a very regular rate usually. This is just shorter than that, which allows our P wave to conduct through the AV node. If it had been earlier than this, then we would have ended up with a refractory AV node that couldn't have conducted, but it was just at the right time to capture the ventricle and for a sinus and intrinsic beat to go in. And then our VT carries on. We can also have the same thing happen, but this time round, the P wave arrives slightly later. And so we get a combination of our VT beat and our sinus beat. So we end up with a fusion beat, which is halfway between the two. And again, these appearances are both very, very strongly suggestive of VT because they show you that you've got atrial activity going on. And here you can also see P waves, which also then give you your diagnosis. The P waves here as well. This isn't the greatest ECG. I need to find a better one, but this is trying to tell you a specific type of VT. Can you tell me what that specific type of VT is from this ECG? Yeah, very good. It's torsade de pointe. Excuse me. So torsade de pointe, you have the electrical axis corkscrewing round and round and round. And this classically, you can give some magnesium to terminate. It's pretty rare, and that's why I don't have a 12-lead ECG of it. I live in hope that I managed to capture one before. Problem is, you usually cardiovert patients quite promptly. So torsade de pointe. What about this ECG? Yeah, this is a 12-lead ECG that you really don't want to have captured under your watch. So if it happens before you get there, that's fine, but you don't want somebody to do it because you've asked for a 12-lead ECG. So this is ventricular fibrillation. You can see that this is relatively fine VF, and it's completely irregular. It's not forming any sort of a pattern. This isn't torsades because it's not corkscrewing around. That's what you might confuse it with, but look how broad and unpleasant looking this is. So this is ventricular fibrillation. Wonderful. So that's all from me on tachyarrhythmias for now. I hope you found that useful. Please do the feedback forms, get your certificates, and tell me what you'd like in future teachings that I do on ECGs. If there are any questions, very happy to take them. Next week we have heart failure, my absolute favorite topic. The reason I love heart failure so much is because it's an area that you can make such a difference to. It's so underloved by people, so much pathology out there that you can really make a difference to patients with. And you guys out there when you're not doing cardiology. So please listen for next week's heart failure talk.